dignitaries, BC, respected BC NAA, respected BC Imam, Government Ayurveda College, Vijayapur, then Principal, Government Ayurveda College, Imam, Government Ayurveda College, Vijayapur, and other respected dignitaries. Actually I am privileged to be participating in this occasion. As a part of the International Surgical Medical Conference Society 2026, organized by NIMA Society Center in association with Imam Government Ayurveda College. Therefore, first of all, I would like to express my sincere thanks to the respected organizing committee members of the NIMA and the whole family members of NIMA and my respected teachers and beloved students, Imam Government Ayurveda College, Vijayapur, then respected delegates and other lecturers, various parts of India or anybody abroad. Today I will present the topic in this esteemed academic platform, the topic luteal defect and infertility, a case-based approach. You see, the incidence of abortion in place, both patients conceived naturally and those undergoing in vitro fertilization and embryo transfer. The clinical abortion rate of general population is approximately less than 25%, whereby in IVF programs the rate increases to approximately 35%. I would say the case first because it is a case-based approach. See, a 34-year-old lady married since 13.5 years with previous history of G3, P0, A3 with irregular periods for infertility treatment. History of PCOD, 13 years during that period. Then minimum endometriosis, stage endometriosis for 4 years. IUI 12 times, everything recorded. And evidence kept from different centers and ovulation induction several times, around 20 times, and IVF and embryo transfer 3 times. And a recent ultrasonogram finding unfavorable endometrium, that is less than 3 millimeter even in the late reproductive phase. Dr. Basisari, she started treatment for oligomenorrhea and primary infertility for 10 months of marriage. It's very early she started the treatment in a government medical college on 19th April 2007. PCOS diagnosed and the treatment started for ovulation induction and IUI. Within 8 years, she was treated in 2 more other higher centers. Up to this period, 10 times IUI done, again 2 more IUI from another center. And hysteroscopy done on 9 September 2016, endometriosis diagnosed and treated. Hysteroscopy laparoscopy done on 24th July 2017 for IVF. The first embryo transfer on 6th September 2017, serum beta HCG was 4,295 microinternational unit per ml. Without any issue, pregnancy continued up to 21st week. Unfortunately, pregnancy lost on 29th January 2018. Second embryo transfer on 23rd December 2018 after 11 months of pregnancy loss. On 7th January 2019, beta HCG was 1,275 micro-international unit per ml, but no significant rise of HCG further and late bleeding occurred. Third embryo transfer on 26th 2019 after 6 months. On 14th July 2019, beta HCG was 103 microinternational uniparamid slight increase of HCG later bleeding occurred. These are the documented prescriptions and documented treatment pathways. It is better to go for IV. See, IV protocol begins. Then number of oocytes correctly 23, fertilized number 30. Then previously I told that the first beta HCG 4295 microinternational unit per ml. Then and see here the history: 31-year-old lady married since 11 years and 6 months, primary with the embryo transfer done on 22nd 8 2017 was admitted for DIY. Unfortunately, the pregnancy gone. Then second embryo transfer you can see. Then third embryo transfer also done. See, here USG finding of further follicular studies with the induction. Findings after third embryo transfer on 28/11/2019, that is 11th day of LMB, the proliferating endometrium only 2.2 millimeter. Then 1 month after, on 27th December 2019, 11th day of LMB, the proliferating endometrium only 2.7 millimeter and remarked as unfavorable endometrium for further embryo transfer and treatment of the allopathy side. Why is it so? Everybody know she was subjected to ovulation induction several times, around more than 20 times with the confidence rate due to its anti-estrogenic effect on endometrium. Now here documented the unfavorable endometrium. This is also unfavorable. All these from modern. On 27/1/2020, the patient came to me for Ayurveda treatment for getting adequate endometrial thickness and for infertility treatment. She has given her menstrual history as only the interval more than 120 days without steroid and the duration of bleeding 1 to 2 days, minimal quantity. I wrote out the husband having moderate asthenospermia. It is negligibly small as far as our treatment protocol is concerned. The treatment started with medicines for oligomenorrhea and cycle regularity. I have given first tablet ashwagandha 2 BD, then capsule procastoid, one patent drugs. The main ingredient is Sukumara and the Kaila 100 milligram, then Leshina tablet 2 BD, then Kalyana Kashaya, prepared Kashaya I have given 20 ml BD, then Sukumara Kala 20 gram BD along with the Sadapashpachana 5 gram BD. Then after 9 months she got the natural cycles within 35 days of interval. I would say the subject, okay. See, the patient will be there. Uterine evaluation. How? The uterine favorability is very important for implantation and pregnancy continuation. Normal adult uterus measures 6 to 10 centimeter long and 3 to 5 centimeter width. The uterine problems may be in the musculature or the myometrium or in the cavity. In the myometrium, problems like fibroid and pneumocystis. Then in the cavity where congenital malformations like bicornuate, unicornuate, complete, incomplete or arcade uterine septa. Then adhesions or obliteration of the uterus, cavity polyp and or problems in the endometrial lining. The endometrial evaluation includes the endometrial receptivity. It is the quality of the endometrium attached, embryo attachment and implantation. that depends upon the main five factors: endometrial thickness, endometrial pattern, endometrial blood flow in the spiral arteries, hormonal status, and molecular factors. One by one, first endometrial thickness. Everybody know endometrium grows approximately at a rate of 0.5 millimeter per day in the proliferative phase and 0.1 millimeter per day in the secretory phase. Thickness more than or equal to 8 millimeter in the pre or the late proliferative phase is associated with a higher pregnancy rate. Thickness less than 7 millimeter is thin endometrium results, poor outcome. It is commonly associated with the estrogen status, uterine blood flow, or the endometrial responsiveness. Endometrial pattern. See, a typical triple-layered or trilaminar pattern of ultrasound finding in the late proliferative phase to be more predictive of pregnancy. Nowadays, the pattern is simply described as multi-layered or non-multi-layered. The patients with the low estrogen or excess androgen generally have single-line endometrium instead of triple line. Low estrogen or excess androgen. For example, in PCO patients, there is hyperandrogenism, which leads to poor endometrial priming due to the inadequate development of the proliferative phase, and which results in the hypoestrogenic states. See, this is the endometrial thickening pattern in the menstrual cycle. Menses day 1 to 5, the myometrial contractions are frequent and the thickness less than 4 millimeter in order to express the shedded endometrium. Then early proliferative phase, day 6 to 10, the triple line pattern is visible due to the dominated estrogen effect and the thickness 7 to 9 millimeter. In late proliferative phase, day 11 to ovulation, well defined triple line. Triple line used in the thickness 9 to 11 mm at ovulation. After ovulation, in the luteal phase, the triple line pattern disappears due to progesterone influence, and the endometrial appearance becomes similar to myometrium and thickness 11 mm or more. You can see the typical triple layered endometrium ultrasound finding. You can see here a silver line. The silver central line indicates the endometrial cavity. This is the endometrial cavity. It is hyperechoic, and just lateral to the central echogenic cavity is the functional layer of endometrium. Functional layer of endometrium having stratum compactum and stratum spoitum, and laterally the hyperechoic basilar layer. This is the typical ultrasound finding of the secretory endometrium. Here, the triple line pattern disappears, and we cannot differentiate the endometrium from the myometrium. Only single line we can see. The previous one. How much endometrial thickness is too much? See, just as thin endometrial layer is a problem, too thick can also be issue. The endometrial hyperplasia, which usually occurs due to excessive estrogen level, and the thickness becomes more than 15 millimeter. Endometrial hyperplasia is referred to the excess proliferation of endometrial glands and stroma due to the prolonged unopposed estrogenic effect without progesterone balance. Usually occurs especially you can see in obese patients and those who are undergoing hormone therapy without progesterone treatments. It is clinically important because it can progress to endometrial carcinoma if treated properly. Then blood flow in the spiral arteries, supporting factor of endometrial receptivity. See, estrogen produces vasodilator effect on the endometrium, which in turn leads to adequate blood flow in the spiral arteries. A reduced level of estrogen could prevent the endometrial growth and proliferation, resulting in thin endometrium. See, due to the inadequate blood flow in the spiral arteries. Then secretory endometrium. Following ovulation, the secretory endometrium is induced by the corpus luteum only if the endometrium is first drained with the estrogen. No, estrogen induces progesterone receptors in the endometrial cells during the proliferative phase. Without this, the progesterone will have no effect on endometrium because progesterone is a non-hormone. It has no action of its own. Some other qualities, it exerts uterine relaxant effect and also exerts anti-follicular effect, anti-ovulatory effect. You should keep in mind. Then, see, what is luteal phase? Simply the second half of menstrual cycle starts after ovulation and ends with menstruation if pregnancy does not occur. The average duration is 12 to 14 days is the luteal phase length, and place the as a practical guidance according to or a clinical practice, 10 to 16 days also can be considered normal. Then, which plays a crucial role in preparing endometrium for implantation. The window of implantation occurs 6 to 10 days after ovulation. That is, day 20 to 24 of the menstrual cycle is the window of implantation. What is luteal phase defect? It is a controversial issue characterized by inadequate endometrial maturation resulting from a qualitative or quantitative disorder in the corpus luteum function, followed by inadequate progesterone secretion or an insufficient duration of progesteronic activity. If it is less than 10 days, progesteronic activity can lead to luteal phase defect. For a lag of more than 2 days in the histological development of the endometrium compared to the day of cycle, it creates so many problems. Pre-ovulatory follicle, the deficiencies in the pre-ovulatory follicles, corpus luteum or endometrium, both in proliferative and in secretory phase. This is the etiology. I am not going to analyze one by one how, why. The ovarian causes poor follicular development and inadequate corpus luteum formation, and hormonal balance, LHSR. There is then hyperprolactinemia, excess prolactin level inhibits GnRH and leads to inhibition of LH as well as FSH, and then altered gametogenesis and steroidogenesis. Then thyroid disorder, both hypo and hyperthyroidism can result in this. In hypothyroidism, there is increase in TSH, which directly acts on the galactophore cells of the anterior pituitary and producing this prolactin, then which alter LH and FSH. In hyperthyroidism, there is increase in T3 and TSH, simultaneous increase in SSBG, which binds the overall estrogenic level, and there is decrease in concentration of estrogen. There is sudden rise of LH and FSH, and there is unfavorable LH surgery results anovulation. Then endometrial factors, the progesterone receptor defect, altered gene expression, stress, obesity, or undernutrition, these are the factors affecting. Then role of implantation markers. The successful implantation is results under the synchronized interaction between the blastocyst and the receptive endometrium. The endometrial receptivity is controlled by specific molecular signals known as implantation markers. See, amongst the most important are integrins, leukemia inhibitory factor or LIF, then hoxatat. These markers are maximally expressed during the window of implantation days 20 to 24 of the menstrual cycle. Then poor expression results first. The first one in the green, it is a cell adhesion molecule seen in the endometrial epithelial cells and trophoblast surface. It acts like molecular glue or adhesive or gum. It has gum-like action. Then it mediates blastocyst endometrial adhesion. It helps the firm attachment of blastocyst in the endometrium. Peak level during the first implantation day is 20 to 21st day of menstrual cycle. The low expression is seen in implantation failure, luteal phase defect, infertility, and endometriosis. The second one is the LIM, is the cell signaling cytokine. It is very important. The production sites endometrial glands and stroma. It activates the intracellular signaling for implantation readiness and promotes blastocyst implantation and trophoblast inversion, regulates immune tolerance and prevent embryo rejection. Then clinical significance, low level is seen in unexplained infertility, recurrent implantation failure. It is essential for cytokine for successful ART outcome. You see, each menstrual cycle is a potentially fertile one, everybody know. Due to the continuous action of progesterone, the secretory endometrium produces these implantation markers. Mainly this one, the cell signaling cytokine, helps to prevent or inhibit the prostaglandin stimulation, thereby leading to the contraction frequency of the uterus, especially on the implantation site. See, and it conferring the immunological privilege to the embryo, thereby preventing embryo rejection from the maternal immune system. Different proteins are interacting. See, maternal and fetal tissues come in direct contact without rejection suggests the immunological acceptance of fetal graft by the mother. The maternal and fetal tissues come in direct contact without rejection suggests the immunological acceptance of fetal graft by the mother. Everybody knows Satmeja, one of the important powers described by Acharya Charaka. It has crucial role in implantation. The Satmeja power can be considered as the cytokine role of this factor. Then Hoxatin gene or transcription factor, homeobox gene, it helps to maintain assets. What previously arranged, it helps to keep assets. Then the production site, endometrial, stromal and epithelial cells, then upregulated by the progesterone peak during the luteal phase. Upregulation and downregulation, I think everybody know. No? Yes, during upregulation, there is coming up of the receptors and activate its receptiveness in order to protect from lower level hormonal stimulation. Then regulates integrin and other implantation molecular expression. Then the clinical significance, low expression is seen in poor endometrial receptivity, PCOS, and endometriosis. Then according to Ayurveda, fertility depends upon normal functioning of four essential factors: Ritu, Kshetra, Ambu and Bija. Drun, Charnam, Sanidhya, Gafasya, Vindhipurvakam, Ritu, Kshetra, Ambu, Bija, Samanya, Giroeta. The Ritu appropriate functioning of proliferative and secretory phases, that is Ritu Purvakala and Ritu Vedidakala, or the proper implantation window. Then Kshetra is the quantitative or qualitative adequacy and proper functioning of endometrium. Kshetra is the field of implantation. Kshetra is the field of implantation. Ambu, adequate endometrial nourishment and hormonal status. Then Bija is the healthy gamete. According to Ayurveda, LPD is Ritu Vedidakala Vyapat. Ritu Vedidakala Vyapat. Then this condition characterized by inadequate support of Kshetra or poor endometrial growth and receptivity, inappropriate Ritu or luteal insufficiency, deficient functioning of Ambu or inadequate endometrial nourishment and deficient hormone protection, then unhealthy Bijas or embryo. Then doshic involvement, you can see there is
is involvement of all the three doshas in LPD. The Vada dosha Bhakti results altered ovulation, unstable proliferative and secretory basis. Then Pitta dosha Kshaya is there, which results inadequate progesterone secretion and luteal insufficiency. As far as female infertility is concerned, we have to dominate the physiological Pitta. And Kapadosha Kshaya, poor endometrial growth, poor follicular growth and receptivity. Some Ayurvedic conditions, repeated pregnancy loss is the characteristic feature of Putrakini Yoni Vyabha. On the basis of clinical features, this condition can be correlated with LPD. Jauksha Vayu Radharpam Jadam Vinashe Dushta Shonita Nagya Putrakini Namasasmada. Similarly, Vamini, another condition described by Vapada, which is believed to be implantation failure due to inadequate endometrial receptivity. Shadaha Saptaratra Vasukhan Garphasatmane Vamesar Nirjavasyasa Vamini. How to diagnose LPD? Mid-secretory serum progesterone level, 21st day of secretory endometrium. If the progesterone level is less than 12 nanogram per milliliter, is definitely diagnostic of LPD. Then sonological study, when the endometrial thickness is less than 8 millimeter in the late proliferative phase, or absence of trilaminar pattern of endometrium, or high pulsating index of low pulsating index is needed. Then endometrial biopsy, a lag of more than 2 days in the histological development of endometrium compared to the day of cycle. Nowadays it has no applicability. It is much difficult to compare this day of cycle with the histological development. Then clinically also you can analyze LPD. A detailed history of luteal phase length. The luteal phase length should be between 12 to 14 days or 10 to 16 days. Less than 10 days is definitely luteal phase defect. And it can be found out by monitoring the basal body temperature. If the higher thermogenic defect less than 10 days, definitely LPD, and there is a rise of 0.4 to 1 degree Fahrenheit during the luteal phase. See, it has been empirically proved that some Ayurvedic combinations or formulations having natural estrogen-like or progesterone-like action. This is of my concept. Then such drugs can be effectively substituted in poor endometrial priming and luteal phase defect. Around 12 or 14 years back, I have presented this protocol Ayurveda college with these concepts. These formulations or drugs supposed to have progesterone-like action. Bhalagrida, Pailakshira Kashaya, milk with the Lakshmana Mula preparation, other drugs described in Bumsavana, Mahadhanundaram or Dhanundaram tablets, Shivalingi, Diplo, Cyclosporin. Then those drugs or herbal mixer products provide uterine relaxant effect prior and during pregnancy, which offers progesterone-like action. Preconceptional administration of such drugs induces a decrease in uterine contraction frequency for the day of implantation, especially on the implantation site also. The Sukumara is supposed to have estrogen-like action. It has been administered during the proliferative phase for getting estrogen-primed endometrium. Then only we will get the progesterone receptors. See, effect of estrogen varies with the dose. Everybody knows this. Small doses of circulating estrogen produces negative feedback effect on hypothalamus and pituitary to inhibit the secretion of androgens. Similarly, elevated levels of estrogen produces positive feedback effect on LH secretion by promoting the responsiveness of pituitary to GnRH. On the basis of those, we can apply this general principle on the treatment aspect. See, I have already told that Sukumara Hida supposed to have estrogen-like action. So low doses or Vijayana Sayavana of Sukumara Hida is suitable for proper endometrial priming, and large doses or Achabana is suitable for producing positive feedback effect on LH secretion and thereby ovulation. Again, I am telling this is my concept. The role of treatment should be from preconceptionally till the stability of fetus is confirmed. Route of administration may be oral, anal, or vaginal. The preconceptional treatment modality after preparatory procedures, Yogavasti, and this is the principle. My patient is waiting there. After preparatory procedures, Yogavasti and Uttaravasti can be administered. Preparatory procedures include Vartana, Abhyanga with powdered medication, then Akshabana with the Sukumara Karda, Abhyanga and steaming, then Murdu Virejana, mild relaxation with the Gandhar Merenda 15 ml with hot milk. Vadastamana Virejana is good. If you are applying Ayurvedi, it is with the Virejana. Then main procedure Yogavasti followed by Uttaravasti. The dosage for Kashayavasti in this Yogavasti modality, we applied minimum or moderate dose firstly. Otherwise, 1000 ml total. This, honey 120 ml, Saindava 15 gram, Dhanundaran Chikkanabagana 120 ml, Sadapushpakarta 30 gram, Balakshila Kashaya 240 ml, Uttaravasti last 3 days with the Bharakrita, intravaginal level administration. Means it is different from douching process. Douching is just washing process. This is Uttaravasti retained for at least 45 minutes. The patient has to wait acid. See, vaginal route of drug administration gives more effect. Orally delivered medicines have the due to the hepatic cause effect, the bioavailability is less than 10%. But this route is very good. The Madhyama Bhaga or Chikkana Bhaga drugs of either ghee or oil preparations having tissue level absorption, because the pH, then the solution rate, the consistency, everything are suitable for mucosal absorption. It diffuses freely into cells and bind the concerned receptors, either progesterone receptor or estrogen receptor, and exert desired action. Then medicines after discharge, Sukumara Karda with Shatapushpa Churna, that was 20 gram BD along with 5 gram BD. Then Kanasada Kashaya 25 ml, it is prescribed in Sadasara Yoga. Then prepared, this is prepared Kashaya, that is why 25 ml, otherwise 96 ml in divided doses, classical preparation. Then up to 18th day of LMB, Parasurface 20 milligram 2 times daily from 19th day of LMB. Pushpe Vigam Parayat, due to the anti-follicular effect of progesterone, Parasurface is supposed to have progesterone-like action. So you should advise only after ovulation. Then only you will get the result. Due to the anti-follicular effect and the anti-ovulatory effect. Moreover, progesterone is Ushna-Snigdha. Progesterone is Ushna-Snigdha in character, that can be compensated with the Parasurface. See, then this is the OP. See, I have given only oral route administration for that particular patient. Patient conceived UPT positive on 25th June 2021. LMB was 11 May 2021. First AD antenatal scan on 6th 7 2021. You can see the impression. I carried over to next slide in more legible. The AD is single, slightly irregular appearing intrauterine gestation sac-like structure. Mean gestation diameter. Gestation sac diameter 4.1 millimeter, corresponding to around 5 weeks. This is the scan report impression. No fecal pole or yolk sac identified. Mild surface area is also present. Next scan you can see. You can see the impression. This is also carry over to next. Early single live intrauterine gestation corresponding to 6 weeks or days. Expected date of confinement 14 March 2022. If the internal os is closed, upper uterine segment having some pathological conditions like that. As per LMB, 11th May 2021 EDC was like this. Then as per USG, EDC was like this. Around 1 month difference. Then I advise the patient for routine antenatal care in a modern WNC hospital. They given monthly folic acid up to 4 months and iron and calcium for 12 weeks onwards. Then the obstetrician advised the patient strictly. You should follow Ayurvedic medicines throughout the antenatal period. They are fully aware of this case. This modern hospital, I am getting hundreds of references from this hospital for especially for endometriosis cases. Documents reference here with them. In the back itself is. Then this Dhanandaram Guliga 202 up to 37 days. Bella Kshirabhaga. Bella prepared with milk and water. Then 1 month from 12th week. Bella surface up to 28th week. ST Madhu Kshira preparation with sugar 2 times daily for 1 month. Then this also the periodical scans. You should not be impression only. Yes. During 36 week scan, single fetus gestation age 34 to 35 weeks, IUGR is there. Then and AFY only 9. Then I advise the modern doctor frequently contacting to me. What are the things you can do? They then advise Indikanda Krida 2 teaspoon BD with milk and ST Madhu Kshiravaga preparation with this sugar 2 times daily. You see, you see, extract that you can see here, long period of infertility. They reported, that particular allopathy hospital reported long period of infertility extracted by a vertex patient. Yet term, life made baby 2.14 kilogram at 2:1 p.m. Occurs for and such, then post-operative period is uneventful. This highlight here. The impression itself is here. Then she conceived again after 2.5 years and delivered another baby. The antenatal care with allopathy hospital means we have no conflict between the allopathy and Ayurveda. They are always supporting me. That the concerned gynecologist was one of the professors in the Government Medical College London. She is advising. A healthy embryo requires a receptive endometrium. Luteal phase is the bridge that connects the two. Diagnosis and treatment of LPD are still controversial. As a result, the treatment remains an area of art rather than science. We are applying the classical as well as the logic. Then only we will get the result. We have our own pattern in the classic, slightly applying the logic also. But anyway, you have to study the anatomy, physiology, pathology, and everything well. Then only you can treat. These are the tools to identify what are the things described in our class. You should use the modern knowledge as a torch to identify what are the things present in our classes. Okay.